For the sake of time, I will introduce the first speaker, who is Ashwin Agarwal, and he will present on pinhole pupilloplasty.
Thank you, Boris, and thank you, AIOS, for having, and Vardhaman specifically for conducting this session so well. So I'm going to be talking something very extremely different. It's called pinhole pupilloplasty. This technique actually is a simple pupil repair. It's a pupilloplasty technique that basically envisages to eradicate irregular astigmatism and complex corneal issues by not dwelling on the corneal surface, by actually going not on the lenticular surface but actually solving this issue at the iris plane. We all have used pinhole on our trial frames, and we've all used the effect of that. We all know the effect of that pinhole when it comes to clarifying higher order abrasions or any abrasion of the corneal at the corneal level. What we're trying to do with pinhole pupilloplasty is using the pupil, shutting the pupil down to a particular size and enhancing the impact to the patient in terms of refractive error. I'll give you a small example of this. If somebody has undergone a radial keratotomy many years back, how does this impact if you do a pinhole pupil years later? I'll just give you a small scenario. You do a pentacam on this radial keratotomy patient, you will find that the RMS, that is root mean square value of the higher order abrasion, will be at about anything beyond 0.5 is a problem. 0.3 is pretty much normal. This patient came to me with a 1.9, and we've gone up to patients who have 20.07, 20.02, that kind of higher order abrasion at the pentacam level. So if you're not looking for this, you will not find the indication for these patients. So the RMS value is probably the first value you want to look for when you're trying to find out irregular astigmatism or irregular corneas. Second step is we do a pre-op ASOCT to see what is the size of this iris. You know, the iris can be dilated at some points, it can be, you can have a Urid-Zavalia syndrome, and so on and so forth. So you want to be aware of this. Next, post-RK patients usually see something like this through a dilated lens. The minute you're able to bring the size down to a 1.5 to 2 millimeter permanently, that's when you can really impact this visual effect and the refractive change. This is the same principle that the West is trying to follow for the AccuFocus and the IC8 or the lens, the pinhole lens, IOL. Now just taking this effect, if this patient came to you a little bit dilated at this stage, they will not be happy. So what we're trying to do, I'm showing you the surgical procedure here, and just because of interest of time, I'm going to do away with the lens extraction and the IOL placement. All that goes as per normal except for the incision. Of course, in RK you have to be a little careful with the incision size and the incision placement. Now I'm trying to bring this pupil size down permanently by using pupilloplasty technique called single pass 4-throw pupilloplasty. Or you can use any technique, CPSAs, modified CPSAs, mecanals, modified mecanals, any procedure that you feel. The idea is to bring the pupil size down. Once the pupil size is down, you might find a cat eye effect. The cat eye pupil effect you can find in this case. So we use a vitrectomy to make it particularly round with the first Purkinje image hitting the center of the pupil. That's the main agenda here. Once you have attained this central visualization of the Purkinje image 1, and obviously you have to center the head, you have to make sure that that position is absolutely right. Once that is done, you will get an effect of this post-operative. Just 2 weeks post-op, you'll get a 6/6 or 20/20 result. And you might be having a small change in the corneal higher order abrasion. It was 1.9 if you remember in the beginning, and post-operatively you are coming out to 1.4. But it does not drastically go away. It does not go away from that value from 20 to 0.3, which is never going to happen. So we have to always anticipate these things before and after. And that's the impact of visual change that the patient is seeing. Now, one big question, and this is the size of the pupil on 2 weeks post-op, 1.29. Big question. retina, how am I going to examine the retina? You're making this size permanently, blah, blah, blah. I mean, these are not the question that my patient is asking at all. They are not asking this question. We are asking each other this question, which is fair, and I think it's a fair question. But if you use the new age fundus cameras, you get a 160 at least, if not 180, but 160 degree good view of the fundus, and you are able to view this. This is the Nidec Mirante. Obviously, I have no financial interest with them, but you can use any of the others as well. Some other cases where you can use pinhole pupilloplasty is post-LASIK. You can see the striae. They will never go away. You can keep ironing them. This is a 20-year-old case. Here you have pellucid marginal degeneration. You cannot take away the higher order aberration. You do a PK, you can do all of it. You'll still struggle getting post-operative results of 6/9, 20/30 kind of vision. Here you have a post-PK patient where ideal choice which most of us, 99% of us will make is do another PK on this. I mean, take this out and do a new PK. But don't, just do a PPP. You'll be perfectly fine giving them a 6/12 vision, which you'll anyways get with just doing a PK as well. So these are some of the options where you really need to start dealing with this at the iris plane if you have a good iris. That being said, thank you very much. Just wanted to introduce a concept of pinhole pupilloplasty to all of you guys. Thank you.
Thank you, Ashwin. Any questions from the audience or from the panel?
I think we'll be running short of time if
yeah,
we do
we're
questions.
Running,
we'll do questions after
late.
4, 5, 6.
Yeah. So my pleasure to invite the next speaker, Dr. Partha Biswas. Of course, he doesn't need any introduction. And he would be talking about a very important topic in phakic IOLs, which is about sizing and how to get it best fit all the time. Thank you so much.
Thank you very much, and I'm really happy to be a part of the Refractive Specialty Day. Thank you, Sheetal. If I open my statement with so how many of us do phakic IOLs? Okay, so for us who do phakic IOLs, this topic is important. But for the ones who do not do phakic IOLs as yet, the topic is supra important. Because this is one place where if we are not accurate, despite our understanding, if we are inaccurate, this can lead to problems, and how to manage these problems are going to be very important. And this particular aspect of sizing is something that deters a knife surgeon to go in for this procedure, though he might be a very, very high volume cataract surgeon. So what are the pearls of this white to white? And there are certain measurements that we need to take during for the sizing of the IOL. And the anatomical white to white is what is calculated, and this has been the norm and the protocol when we do a sizing of the ICL. So let's look at the meta-analysis, and in this particular study, 77% of the eyes had acceptable or ideal vault calculated with the white to white. And there was this large number of 1387 which were followed up for 10 years, and overall the surgical intervention post ICL was just about 0.8%, which really means that the formula that we are sticking to is a good formula until something better comes in, or until more variables are placed into the formula to derive a better and a more consistent ICL dimension. This should work. So it is a methodology that is proven and superior in terms of predictability of the vault to use with the white to white and the ACD, which remains the most popular and the best studied technique. And if we keep these in mind, then how do we go about it? So the white to white with a caliper measurement is something that is very important, and you have to measure the white to white. There is a gray zone just beyond the dark zone of the limbus, and there is that white zone just after the limbus ends. So if you have a large gray zone, you need to measure the mid of that gray zone from the gray to the white so as to be as accurate as possible. The caliper has to be very well calibrated. The eye, of course, has to be pre-treated with anesthetic drops. The eye should not be dilated, because if we are taking it on the microscope light might be too strong and the eye might be moving all the time, and you might injure a part of the cornea or the conjunctiva while taking the measurement. Patient needs to be in supine position. It is best to have a caliper measurement with the operating microscope in the OR room. However, certain very experienced surgeons do take it on the slit lamp, and if there is a proper predictability, one can go ahead with that as well. So we know that the OB scan was a very, very accurate measurement of the white to white, but we do not have the OB scan at many situations now, and thereby the IOL master has become an important tool. However, the IOL master overestimates the white to white, and we have to be very cautious about the pterygium pigmented areas and any discrepancy between the two eyes. If there's a discrepancy between the two eyes, you have to be very careful, because this usually does not happen. And the eyes should have approximately same white to white measurements. So if you look at the ACD, and the ACD is defined as the distance between the corneal endothelium and the anterior crystalline lens, and this has to be measured, and this can be measured both by the OB scan or the IOL master or the pentacam as well. Now let us look at this IOL master reading that it gives, and you can see that it shows a white to white of 11.3. When we measured this patient with the caliper, the digital caliper, it gave us 10.72, and that was consistent. So it is the digital caliper that we'll take into value. However, what we will do is we will remember that there is this particular difference of about 0.6 to 0.7 microns between the digital caliper and the IOL master, and that should be as consistent as possible. So it actually gives 0.57, 0.6 to 0.7 is what you can take, and the pentacam shows a high by 0.2 millimeters. So the IOL sizing and the ACD value is provided by the OB scan, or you can use it from the pentacam. And when you have the ICL sizing, the vault is something that you have to be very particular about. So 250 microns to 750 microns is what a normal vault is to be. However, we'll come to that part later. If it is an undersized and less than 0.125, should we go ahead and explant this ICL? Will it cause cataract? So that is something that we need to answer, and the answer is we should not jump into explantation unless it is less than 100 microns. If it is 50, 70, 80 microns, we should explant right away. But if it is up to maybe 100 microns and plus 120, 25 microns, we can still wait and watch. But it is an undersized ICL and you have to watch it. And oversized ICL more than 1,000 microns may push up the iris and close the angles, as we know. And this is a high vault ICL that you can see. So a small PI has been done for this patient. We are following up this patient for quite some time now, and this patient is not doing too badly as of now, even with a high vault of about 800 plus. So this is something with a low vault, and a low vault has to be very, very specifically followed up. Now look at this slide that we come to the next one, and you can see that we did an ICL, and on day one follow-up it shows 189 microns. When we ask the patient to come back after a week, it shows 260 microns. A month later, again it's 189 microns. 2 months later, it is 83 microns. 5 months follow-up, 112 microns. Same machine, same calibration of the AIOC2024, and this is a variation that we noted. Now, we are following up this patient. We definitely do not want to take out the ICL, and it's only clinically if we feel that there is some amount of cataractous change coming around, it is then that we should take out this ICL. However, if it is less than 100, please explant the ICL and put in a fresh ICL, which is not a difficult proposition at all. Now let us look at this one with a high vault more than what you expect, and day one it is 804 microns. But a week later, this comes down and it is 598, and 2 months and 5 months follow-up, it is at around 533 and microns. So which could mean that there was some amount of viscoelastic left, and this possibly got removed during the course and it settled. And this is what we have. So let's not be too hasty in explanting an ICL, but if it has to be explanted, it is not a difficult thing to do. So a quick show of how we explanted this ICL, and it was a toric ICL. So it's not difficult, but the right technique has to be done. And here what you can see is I'm prolapsing out the proximal haptics, and once the proximal haptics are prolapsed out over the iris, then with the same forceps we pull it out, and hand over hand we remove the ICL. It is important that we use high molecular weight viscoelastic. Another thing that is very important is not to prolapse out the distal haptics together. Then what happens is the proximal and the distal haptics, if it sits on the iris, then it becomes a convexity, and you cannot get a hold or a purchase on the ICL. So it's very important that while you're removing with your forceps the ICL, it's only the proximal part that has to be prolapsed out of the sulcus, and thereby you can get a good purchase and remove it. And placing the ICL back again, the right ICL back, is not so difficult, and it's just that the iris will tend to come down a little, but you can use viscoelastic methyl cellulose, even if you can use sodium hyaluronate, and it comes out in a bolus. So thank you very much for your patient hearing. To conclude, selecting the appropriate sizing and the visual outcome and the patient satisfaction is important. Meticulous preoperative assessment and intraoperative planning. A very consistent follow-up in these patients who are either undersized or oversized, and prioritize the precision, and that's the journey to a clear vision. Thank you very much.
Thank you, sir, for that excellent talk and sharing all your pearls and wisdom on the phakic IOL sizing and showing all those interesting cases. So the next speaker. Yeah, so my pleasure to invite Dr. Samaresh Srivastav, youth icon in Indian ophthalmology, and has won a number of international and national awards and has made India proud at all these international forums. And he will be speaking on phakic IOL indications and pre-op workup.
Thank you for the lovely introduction, Dr. Sheetal. I think you may have overtaken me in the awards. Maybe we'll have to do a count on that at some point. So I'm going to discuss basic of pre-op workup for a phakic IOL patient, ICL patient, and I'll be omitting the sizing part on this. So first thing to understand is what is a good patient for a phakic lens. So in my hands, I don't operate anyone less than 20 years with at least 1 year of stable refraction. Again, patients with high myopia, it depends on whether I treat 9 diopters or more. Sometimes I even treat lower diopters if the K readings are flatter or the patient is not the 100% suitable candidate for a LASIK surgery. And just to show you as an example, this is a patient who's a borderline myope with some cylindrical correction, but because of low pachymetry and steep keratometry readings, this is a patient where I would not want to do any sort of refractive correction in terms of either a LASIK or a PRK. And this is the kind of patient that I will probably push for a lens ICL based or a phakic lens based surgery. Some of the things that I follow in my clinic is always before planning, evaluating both the eyes, not only from the refractive point of view, but also as a complete unit. I start with ocular surface evaluation because a lot of these patients are chronic contact lens users and do come up with dry eyes, and post-operatively their visual outcomes may be marred by a poor ocular surface. It also gives us a wrong estimate of the patient's refractive error. So I tend to do a non-invasive technique. So one of the commonest techniques that I use in the clinic is to do a non-invasive breakup time on my topography, on a Scheimpflug topography. And I think all good new modern topographers do have this as an add-on software, and one can negotiate for free. I also have lipid layer analysis, so I do a lipid analysis and the meibomian gland analysis because for some reason I'm tending to pick up a lot of patients, particularly in Rajasthan, with a lot of lower lipid layer thickness with good glands. So maybe just a week or 10 days of hot fermentation for these patients do tend to work well, and they do open up because their oil secretions do pump up after warm compresses. I also do biometry of both the eyes for many reasons, including the fact that they may develop cataract later, and it's good to have the biometric status. But one thing that I've started to look at in the new OCT biometers is also the configuration of the iris, because the posterior bowing iris in my hands has given rise to a lot of post-operative pigment dispersion. So if a patient has an iris that goes posteriorly like this, so this is the Argos from Alcon, this is the biometer. But I think most good OCT biometers will have a built-in anterior segment module, and if you have a standalone built-in standalone anterior segment machine like a Vizante or something, I think it's worth, apart from white to white or seeing the sulcus, is also to look at the anatomy of the iris, because these patients may land up with issues later. When it comes to cornea, I like to treat only regular corneal astigmatism, and I think that's the norm now. Everybody's looking at it. So it's very important to do a good topography. And again, my choice of topography would be a Placido over a Scheimpflug, simply because of the quality of data that it gives. I do specular for all my patients, LASIK and ICL, and I think I learned this from Vardhaman way back when, the importance of doing specular microscopy in all refractive patients. So this is a patient who's come up with a low myopia in my clinic and was counseled for a LASIK surgery, but the pachy is borderline, it's not visible here. But this is the endothelium. And honestly, I couldn't pick it up on a cursory slit lamp evaluation, and the peripheral cornea is okay. So I do understand that central cornea is a very poor indicator of how the endothelium is functioning. But if you have guttate like this, I would be very wary of doing any procedure, ICL or a LASIK, because of the fear of the flap not adhering well. So this is a very important tool. So if you have a specular, it's always good to evaluate it and document it, because if later something goes wrong, then you don't have to get the blame, or you don't touch a patient like that. Peripheral retinal evaluation is a must, but I also do OCT documentation for all these patients, because their foveal, I need to document the fovea also for medical legal reasons, and because the machine is lying right there, it doesn't cost to click a button. So for whatever diagnostics I have in the clinic, if they have a role in understanding the eye in toto, I will incorporate them in my pre-op planning, starting from the ocular surface all the way up to the retina. Our team published this a few years ago, where we looked at the role of OCT as a diagnostic tool for a cataract surgeon, and we found out, we did a study where we masked the diagnosis, OCT diagnosis, to our retinal consultant, and for all those patients that the retina doctor says are okay, and you can go ahead and put a multifocal lens or an EDOF lens or whatever, they were EM, ERMs, vitreomacular tractions, pseudo holes, everything was being picked up. So it's very important to do an OCT and look at the macula, and if you feel something is subnormal, maybe not treat these patients. I also tend to document an imaging. But the one thing that I've started to do now over the last few years is, having burned my fingers, I also do a gonioscopy, not only to rule out narrow occludable angles, because that I think we can pick up with OCT also, but because I've operated on patients who were subclinical fuchs, and they bled post-operatively. They were 6 first post-op day, and at 1 week they went to Chennai to a colleague's place, and they had an 8-ball hyphema because the iris bled somewhere in the corner. I evacuated and it re-bled again after that, so I really burned my finger, and I do tend to do a gonio and hold it and see if I can, with my limited experience with gonio, any vessel, and then I would be a little scared in operating this patient. This is just a representation image which I picked up from a presentation to show, this is typically what would happen. We all know what Amsler's sign is, and we've seen it in cataract surgery, but there is no reason why it can't happen even in an ICL patient. So it's good to do that. Again, measuring white to white, Dr. Partha has discussed very well, so I'm not going to discuss, except for the fact that I don't like to use bulky instruments in the eye, so I use these old calipers, and then once I have measured the white to white on old calipers, I make a punch on a paper, then I use the digital calipers to measure it, so that I don't want to put that bulky instrument on the patient's eye. It tends to scare them. While the age-old calipers that we were using for extracapsular are very fine and patient doesn't see them in their visual field, so you can do it very quietly without scaring the patient away. Again, this is just to show you, despite all workup and everything, one patient that I would have done ICL for is this patient, and I wanted to show you this because this was just an absolutely normal pre-op workup, and you can imagine the amount of diagnostics that we're doing. Generally, nothing would go missed. So this patient had a very good straight docking, and notice when the laser fires, I'm making a 110 micron flap on a femtosecond platform in an absolutely normal eye. And I wanted to notice, to my horror, what I saw over here. This is an area of uncut tissue. So I did LASIK for a myope, low myope, and this happened. When I looked at the patient post-operatively, and now when I looked at, I did the other eye also, but when I was ironing up the other eye, I could see the central epithelium in the central 4-5 millimeters moving freely. So one eye I abandoned. The previous eye I abandoned. I didn't lift the flap, but I thought maybe it's a paracan or something. And this is what the other eye, fortunately the other eye flap got cut and I fired. God was on my side. And I did call up again Vardhaman and I asked him what's going on, and it turns out this patient had a subclinical epithelial basement membrane dystrophy. So if I had done an anterior segment OCT and evaluated not for Pachy or epithelial mapping but sheer anterior segment OCT and seen the thickened membranes, or done a retroillumination photograph, maybe I would have been wary of doing LASIK. To end my talk, it's not only pre-op but also post-op. Workup is important. Like Dr. Partha said, please evaluate and document slit lamp and on OCT or vaulting. And just to show you one of those, again, freak cases, adequate vaulting for me is 400, 500, and you need to document these patients forever. Also, please keep on documenting the retina. So to end with, this is one of those patients that has been lying with an ICL with 56 micron vaulting for the last 5 years, and I haven't developed a cataract. So while it's important to have sizing and everything, there is something more at play, and the vaulting is not really hampering, particularly with the star ICL in any of these eyes. Thank you.
Thanks, Amresh, for this nice talk. So I would just add a point to that. I think, yes, vaulting, and then you have to see whether there is any peripheral touch. Yeah. And despite the peripheral touch, then you have to observe whether there are any lenticular changes, if the cataract changes are occurring. So if there are no cataract changes, I think these patients can be very well followed. And then sequentially, if you find that they are maintaining as your case, I think they do well. Thank you. So I think very nicely pointed out. So next we have Dr. Kamal Kapoor, and he has a huge, I think he's the largest IPCL user in India, design and experience.
Probably in the world.
Quick 6-minute talk. Your time is cut, Kamal.
Okay, I think I'll go fast.
Sorry for that.
It's a very interesting presentation. I wish I could show you some very, very unique situations where you can't even imagine a phakic lens can be implanted. I've got them customized, made for myself, and done them. Okay, so there are no financial disclosures. I have no financial relationship with any of the products I'll be talking about. I've used all of these phakic lenses, but my major experience is probably with the, I think it's not, got it. Okay, so we start again. So I'll be talking about the design and the experience with this particular brand of phakic lens. No financial disclosures here. I've used all of these lenses and a reasonable sizable number, but I think my maximum experience goes in thousands with the IPCL. There are various options available. Now let's look at the design first, since the topic says that. First of all, if you notice, there are 6 landing pads in the lens. There are 6 landing pads. So what this does for the patient is, if it's a toric lens, it's rock solid. If your workup is perfect, I have corrected till 11 diopters of astigmatism with bang on results in keratoconus, corneal scars, which means that this design works. There are 6 landing pads, which gives a far more good stability. And then if you notice, there are 5 extra holes. Now this is definitely a big plus point for the patient, where there can be less amount of incidence of cataract. It's a non-animal protein. Of course, it can be very important in some religious groups or some countries. It's truly completely customized lens. It can go through a 2.8 millimeter incision. The best part is the angulation of the lens. The edge plate is flat and the central part is raised. So even if you have a very high wall, the chances of pigment dispersion are very minimal, and also occlusion of the angles. So this unique design makes it very, very possible for you to have more forgiving phakic lens. I have corrected up to -34 until 11 diopters of cylinder. There is a central hole, which is again a unique design, unlike the other lenses. It's a taper-centered hole, which makes sure there's less amount of diffraction, internal reflection. It does not give you that much amount of glare, whichever a normal central hole can give. It can be variable sized. I have used till 8.5 millimeter optic size lenses, till 14.5 millimeter of total diopters. It's a very thin lens, unlike the ICL, which is 120 microns. This is 180 microns. So these are the two. I will not go into the materials. The only difference here would be probably the porcine material. Now this is a very interesting study done by Dr. Miguel, and this shows that the surface smoothness of the lens will give you the optical quality. And he, in this study where he was finding less than 0.1 nanometers, he proved that the IPCL is far more smoother than the ICL. Now sizes and extremes of power, we all know the variability of size is amazing. 0.25 point change for each size. Unlike other lenses which come in half a millimeter, you can actually size very perfectly your fitting, unlike a normal ICL or a RIL where you have half diopters. Another beautiful part about the design is you do not need to rotate the lens. You can just put it at 0-180 and it will give you the perfect lock. There's no need for a chart. There's no need for a reference point. All you need to do is mark 0-180 and the lens will land in its place. Now this is a patient 4 years post-operatively, bang at the place where I left it, 0-180. Now this is the diagram which I want to show. A normal lens will have a 360 micron straight cut hole in the center. This gives edge glare. A lot of our patients will come to us saying that they see at night they see a semicircular spot. That's the glare due to this particular circle. But the upper design is a design seen in an IPCL. There's a tapered hole which reduces the incidence. Another advantage is this compressible spring-like edges or the haptics which do not encroach on the zonules, so your stability is higher. The chances of touching the peripheral part of the crystalline lens is far more improved. Size and power availability, we all know. I'm going to wait fast. Now this is a huge plus point. You have 13 sizes available in the IPCL, whereas with a lot of other stuff you can have 4 or 6 or 7 sizes available. You can actually customize down to the last part whatever you want because of these large sizes. Now coming to the optic size, as I said, I've used till 8.5. You can see how huge this lens is. This patient's pupil resting size, scotopic size was 7.2 and he had a power of -17. So I had to do this, so we got a customized lens at 8.5. The patient is doing well. Now this is a cylindrical patient with -3.5 with 11 diopters of astigmatism with repaired corneal scar. Now this patient did extremely well, again due to the stability of the lens. We also have used these presbyopic phakic IPCLs in patients where I've already operated them and now they want some kind of a presbyopic correction. You can use this IPCL in these cases. So I've done nearly more than, this is 3,400 cases till now. This is a little old slide. And they've all behaved beautifully. Just have around 7 to 9 patients of explantation. Cataract incidence, I feel it's all because of a bad sizing or a bad surgeon. Bad optometrist or a bad surgeon. That's what causes a cataract in a phakic lens. Because if you are, while doing the surgery, you're touching the anterior capsule, you're bothering the anterior capsule, that's the time you will get a cataract. Or if your optometrist has not done a good job of doing a good size measurement and you have a little flatter vault or a lower vault or a shallower vault, you will land with cataract. Otherwise, I have a series of 13 years of IPCL with me, no cataract at all. I'm just noticing a little bit of decrease in vault with time, but there are no cataracts. So again, unique situations. I'll try and show you some videos. Now this is a study which I did, which was 300 patients. Majority of the patients were requiring a 12.5 millimeter implant. I'll go fast. Only 7% patients were a little bit on a shallower side of the vault, and I would say that anything less than 400 would be shallow. But I have patients where I have 250 vault also, but since there are 5 holes in the lens, the incidence of cataract I've still yet to see in these patients. Most of these patients, instead of being of superbly high myopic, are doing great. They're all 6'9" and above. Now these are some of the patients, minus 27, this is minus 29, this is minus 34. Now this is the range of corrections you can do for these patients. You can get these lenses customized. Now this is a patient, I'm just showing some quick videos. A patient operated in Ludhiana with Symphony. She came to me, she was a hyperope, and this is a video I think 8 years ago, came to me, hyperopia. I wanted to explant the lens. She refused for a lens explantation. Chamber was shallow. So what do? I get a customized IPCL made, hyperopia +5, and I put the IPCL since the anterior chamber was not very good, and the patient did very well. Now this is again post keratoconus, post intacs. You can see the intacs in this particular image. You can see the intacs here. So for patients of keratoconus where you've done intacs and there's still a residual astigmatism, you can still correct this. These patients do phenomenally well. The only difference is in keratoconus patients, you need not be very, very happy about a high anterior chamber depth because this is a false anterior chamber depth. This is not the true anterior chamber depth. So you should be looking at a good white to white and never ignore the angle. The angle will go down in my study from 15 to 18 degrees post IPCL implant. So if you're looking at an angle of 27, 28, refrain. Do not put a phakic lens. But anything more than 35 in my study, I go ahead and do that. Now this is a patient with corneal scar, heel corneal scar. This patient was doing very well. 11 diopters of astigmatism. This is the same patient. We'll just see this video. 11 diopters of astigmatism. Patient is otherwise fine. No cataract. So this is a young boy. He had a beer bottle injury. He had a fight. He got into a fight and somebody just threw a beer bottle at him. So this is what we do. We put in a toric customized phakic IPCL of 11 diopters. The patient was doing fantastic. This is another patient of a traumatic, I just jumped this. Yeah, this is an interesting case where we have this patient who's coming back to me after 18 years of surgery. Complete total posterior sanique, minus 17 diopters of refraction, small non-dilating pupil. What can I do for this patient? So I go ahead, break the sanique. There's a complete sanique with the anterior capsule. I go ahead, break the sanique, customize phakic IOL, implanted there, enough space for me to work around, and the patient is doing fantastic. 2 more videos and I think that's... Now this is another case operated many years ago, 4.5 millimeter phakic lens. Okay. So thank you.
Thank you, Dr. Kamal, for that powerful talk, as always, and showing all those extreme cases and the utility of IPCL in these challenging cases. So we move on to the next speaker. Dr. Sujata Mohan also doesn't need any introduction. She's prolific cataract refractive surgeon and also has one great experience in the field of phakic IOLs. So she will be talking about RIL design and her experience.
Thank you, Sheetal, and at the outset I'd like to thank the organizers for giving me this wonderful opportunity. I don't claim to do 3,500 cases like what Kamal has shown, so I have a very limited experience with RIL, though I've been doing phakic IOL since 2006. So I'm just going to give you an overview about what is RIL and our little experience with that. And refractive implantable lens is a single-piece foldable phakic IOL which is placed in the sulcus in front of the natural lens to correct myopia, hypermetropia and astigmatism. It's made of biocompatible acrylic hydrophilic material. It has 2 peripheral holes and 1 central hole. So over a period of time they keep changing the design, but I think finally they settled on this. You can see there are 2 peripheral holes and there's a central hole, and it's supposed to give a vaulting somewhere between 400 to 700 microns. It does range somewhere between 200 to 1000, but most of the times it falls well within your expectations. And these 2 peripheral holes are to prevent, to have a good aqueous humor flow for high patient comfort, and also they make sure that every lens is tested for the power, quality and the modular transfer function before they are sold to the market. And looking at the specification, it is the optic size between 4.5 to 5.75 millimeters. Overall size is between 11.5 to 14. And they come with an diopter range of -1 to -24. Astigmatism can go up to -10, and hypermetro from +1 to +3. And they are steam sterilized. They have a very good page stability. I think most of the lenses of uniformly form almost the same design, whether it is an ICL or IPCL or biotech or RIL. Most of them have almost the same design. It only depends upon how accurate the power balances and how good they are in preventing any pupillary block. And here the optic diameter ranges from 4.5 to 5.75 millimeters, and this central vaulting can even go up to sometimes between 1,000 to 1,200 microns. And overall length is between 11.5 to 14 millimeters, depending upon how high the myopia is. And thickness of the peripheral haptic is 100 microns, which I think he was mentioning is almost similar to IPCL. It has two holes, which is about 500 microns here in the optic-haptic junction, and the central hole is about 340 microns. And again, I think we already spoke about the different powers available. And so the power calculation, Partha has gone into detail about what are the important features when you're doing a power calculation. The most important being the anterior chamber depth, where you cannot implant a lens which is less than 2.8 millimeters. White to white is also very important. We also use the digital caliper for calculating the white to white. And most important thing in any IOL power implantation is refraction. So spectacle refraction has to be determined. And looking at the safety factors, make sure that the patient, some of these patients may have very thick pachy, so you have to rule out any posterior endothelial problems. So doing a routine specular microscopy is very important. And preoperative data, so uniformly for all refractive surgeons, go for visual acuity, manifest refraction, keratometry, AC depth, whatever we have discussed. And more importantly in phakic IOL patients, because most of them are moderate to high myopes, we have to do a detailed fundus examination to make sure that they don't have any problems in the fundus. And if they do have, it has to be treated before we take them up for any refractive surgery. So we did a very small study. Our experience with RIL is for a very short time. And this is a retrospective study of about 54 eyes, the age ranging from 18 to 40 years. And the follow-up period was between 3 weeks to 2 years. And we followed all the protocols of the inclusion criteria and the exclusion criteria. And looking at the demographic, almost most of the patients were similar, male to female ratio was very similar. And the age, majority of the patients were about somewhere between 20 to 30. A few of them were more than 30. So you can see the majority of the patients in our group were between 20 to 30. And the refractive error, majority of the refractive error was somewhere between 10 to 20 diopters. And there were 6 patients who were falling below 6, and about 10 patients above 20. So mean anterior chamber depth was about 3.1, mean power corrected was 15.9, and the keratometry mean was about 44. So these were the preoperative evaluation which was done, and all surgeries were performed by a single surgeon. This is a video showing the implantation of RIL. So normally we make 2 side ports, so it helps us to tuck in the plate haptic. Intracameral xylocard followed by viscoelastic is introduced, and a 2.8 millimeter incision is made, and the lens is introduced into the anterior chamber. You can see that the lens is a little bit flexible, so you have to make sure that you are putting it on the right side, and having the the small hole in the haptic helps us to identify which is the right size. So the hole is on the right side in the superior haptic and the left side in the inferior haptic. So it's very easy to tuck in, very extremely flexible, and it can be done by any surgeon. It's not a big game changer. You just have to wash out the viscoelastic. You can use a coaxial IA also to do it. I prefer not to leave behind any air bubble. Completely remove all the viscoelastic from the anterior chamber. It may take a little bit of time because you cannot go under the lens and remove it. Just try to remove it through the small holes which are present as much as possible. So in our results, the mean age was 32.48 years, mean preoperative myopia was 16.92, and the follow-up was between 1 to 24 months. So the uncorrected pre-op visual acuity was less than 6/60. And the best corrected pre-op visual acuity, majority of the patients were within by 6/9, about 20 out of 54 patients. There were a couple of patients who had less than 6/24 or 6/18. Uncorrected post-op visual acuity improved significantly. So 26 out of the 54 patients had 6/6 and 15 patients had 6/9, and none of patients had less than what they had before surgery. The gain in lines, there was a significant gain in lines. About 25 out of 54 patients, almost 50% of the patients had gain in line of one line, and about 25% of the patients had two lines gain, and around 15% of the patient had three lines gain. So that showed that excellent refractive correction that the patients developed. The mean endothelial cell density preoperatively was 3,000 and odd, and at the end of 2 years, there was only a loss of about 5.4. So in our series, just one patient developed anterior subcapsular capacity, which didn't really need any surgical intervention. This could have been because of some retained viscoelastic. And 2 eyes had intraocular pressure postoperatively. And due to retained viscoelastic, which was relieved after oral acetazolamide. One patient had a loss of visual acuity after 2 years due to early macular degeneration. So in our very small series of patients of RAL, we had an excellent results, and definitely it's a very good alternative and should be considered in patients who cannot afford imported lenses, and the results are very good, very safe, and excellent in our hands. Thank you.
Thank you, Sujata ma'am, for wrapping it around and giving a brief overview of these phakic lenses. I think you didn't disclose about the make of this lens that you're using, ma'am? So any particular company that you're using this? Apaswamy, okay, thank you. So it's a pleasure and an honor to welcome Padam Shri Professor Dr. K.K. Mehta, sir. Welcome to this AIOS, and he'll be talking on the role of refractive lens exchange when and choice of IOLs. I think that's a very important topic, and none other than sir could speak on this. So let's hear from him.
Thank you very much for all those very kind comments. You know, as we are now aware, cataract is a refractive surgery. From the viewpoint of the patient, the advantages are that it is fast, reproducible, and be it LASIK or SMILE, refractive surgery is a bilateral, and thus the tendency always is now to do cataract surgery also as a bilateral mode. The question is not whether, I'm not going to dwell too much on the technical side of it, because I think that is something everybody is well aware of. I'm going to dwell on topics or sites which are a little off the line. Why not simply monofocal? After all, reading glasses, people have worn them all their life. And the progressive glasses, as people turn around and say, I'm using a progressive glass, why don't I need to bother? One of the big problems when you start talking of multifocality to patient, I am a multifocal patient basically. I've got multifocal lenses in my eyes also. So I know what I'm talking about. Unlike the progressive glasses which are only functional in the zones, a multifocal lens, I have to tell the patients, they're multifocal at every single site, whether you look up or down. Obvious reasons of trifocal. And the question is, why does the patient wish to be a visual cripple? It does not help him. The only important thing I would like to stress, the most important instrument you can buy is not a biometer or an instrument or a topographer. It is a counselor. Careful counseling is the key to a very successful practice. Whether you wish to go in for a trifocal or a need-off, it doesn't matter, but the patient has to be counseled in detail. There are many advantages of using a need-off lens which people are now stressing down the line. After all, one of the reasons why companies came out with a need-off lens was not because they wanted to sell a need-off, it was simply that they could modify their bifocal lens manufacture by just decreasing a few rings and making it a need-off lens. You get excellent distance in intermediate, and you get a little less decrease in distance, and you get reduced side effects. But the most important thing of all is that you do not get functional near vision, despite whatever the people tell you. Now the criteria of a near vision as far as the patient is concerned is his ability to read his mobile. And do remember, mobile reading is at 8 inches. It is not at 14 inches. Nobody reads the mobile at arm's length. So, I mean, this is one of the problems which come about. And many of our multifocal EDOF lenses are fallen at the side purely because they have not been explained in detail. Now, fortunately, people now, let me give you an example of Rayner, now starts calling its EDOF lenses as an advanced monofocal lens, which it truly is. Irrespective of what lens you choose, the biggest problem is a refractive surprise. And when you go on to doing a refractive surprise, the question is, there are 6 steps to achieve what I call as a happy result. You use a swept, I have nothing to do with any of the companies. As a matter of fact, it's neither here nor there with them. But I basically true believe, and what I believe I will tell you. I believe that using a swept source IOL master is really the way to come. I do believe that you get much more information you get out of these units. It tells you, for example, as to whether your topo has been fixed well, as to whether your keratometry is accurate or not, and as to whether problems are occurring. Number 2 is to use an advanced formula. You can utilize the optimized version of the Haigis or the Holiday or the Biomaster. But the important thing is that you need to know your details of how to handle that. Most important of all, and this is something which is a little, as one would turn around and say, it's a little off the line purely because people don't quite agree with me when I say it, is that posterior keratometry is really important. Don't take it as an optional tool. It makes the difference between the occasional misfire, in which case you are going to lose. Remember, when you misfire on a patient, you don't lose a patient. You don't lose a family. You lose a kutub. Basically, in family, they talk all among themselves and they say, I got this lens and I'm not seeing well. So you lose a lot. Measure the angle and alpha kappa. I mean, these are not theoretical statements. Measure them because it makes a significant difference. The criteria which I utilize is simple. Corneal aberration should be less than 0.4. Angle alpha also less than 0.4. Regular cornea, regular macular OCD, and no mild or dry eye disease. Most important of all is to treat for ocular dry eye symptoms. I cannot stress it enough. I mean, Vardhaman has also stressed on that, but I'd like to really reinforce what he says, because the dry eye will make a difference between a patient seeing 6.9 and seeing 6.6. And these are things people will then crib about later on that I'm not seeing. They turn on and they will never turn around and say it is because of the dry eye problem. They will turn around and say that you didn't give me a proper result. So a drop of fluorescein will save you a great deal of anguish later. In every patient, irrespective of whether you have your measurement techniques for dry eye, put a drop of fluorescein and evaluate case. You'd be amazed as to what you see in a good majority of cases. Of course, you have to place your IOL well and make sure that your astigmatic control is perfectly functional. You should aim for an astigmatic control of half diopter or less, and it should be a minus half cylinder in 90. With that, if you have a residual, you can still get away well. If you are left with a plus cylinder, God forbid, then your patient is going to be very unhappy. You need one of the easiest ways to have a precise IOL measurement system. There are various available in the market. I use the Zeiss, so I talk about it. It has the advantage that you can use a Callisto, gives you the details, gives me the information sitting on the side as I want, so I can literally do what I like. And the big advantage is it enables you to place your lens with a level of accuracy which you don't otherwise have. So the whole system essentially is that you inject your lens inside, and you get the data which tells you exactly at what angle you wish to put your lens in. So you can get your lens in the precise direction which you want to. And that is really important. The most important thing of all is, remember, after you put your lens and have positioned it, to press on the lens, remove the excess viscoelastic from behind. Either you can press it manually or you can inject a little air and let the air press it for you. Because very often if a lens rotates, it rotates because of viscoelastic which you left residual behind the lens. And results properly done, uncorrected visual acuity. This is only a small series of ours, 3,500 cases. Our series are much more. This is only a representative description. Essentially, we find that our accuracy runs mostly within a minus half cylinder, and in the cylindrical correction, we are run fairly accurately. You do have to be careful. Best change and best corrected visual acuity is also quite significant. And the happy patients are there. Now, the most important thing to get a happy patient is counseling. Patients need to be told. People tend to complain about glare. Just remember that half of what the patient tells you is read on Google. So he's just giving you what Google says. So you have to turn around and tell them what you say and not what Google says. You have to turn around and tell them that yes, you will see glare in the beginning, but when the car comes within a 20 feet distance, the glare goes away. You have to stipulate that to them. You have to tell them glare only occurs with major lights. It doesn't occur with street lights. It doesn't occur with a single point source of light if the light is focal or above. It doesn't occur in your clinic, for example. And then it doesn't, for at least ophthalmic surgeons, you tell them it doesn't interfere with indirect ophthalmoscopy. So I mean, these are things which you need to tell your patients. And if you assess your symptoms accurately, the glare, the halos, there's nothing much. Double vision is only occasional. Night driving a vision difficulty, you have to tell the patient that he will see a little less at night. And if he has to read fine print, he needs a brighter light. That is about it. Once he knows that, he is happy with it. Also, you have to tell him that his reading distance is set, is not variable. So it is said, for example, I've got a panoptics lens in my eye. In my case, my reading distance is set at 12 inches. If I wanted to have a closer one, I would have put in a Zeiss, I would have got 8-9 inches in distance. In some of them, it is much further off. But they need to know exactly what they're going to get. And a perfectly good lens, supreme happiness. But remember, and I explained to them all, there is a trade-off. And remember the quotation, everybody wants happiness, nobody wants pain. But you can't have a rainbow without a little rain. Thank you very much for your attention.
Thank you, sir, for that wonderful overview about the refractive lens exchange. I think we'll skip questions and we'll ask Sheetal to give an overview of the biotech phakic lenses. She'll be talking on design and experience. I think Sheetal, a quick wrap up with your own experience with the biotech would help us.
So
and I'll request Dr. Gaurav to be ready with his presentation on the next dais.
Good afternoon.
Thank you.
Good afternoon, friends. So I'll be discussing about the biotech phakic IOLs design and experience. So I've been using these lenses now since past 7 or 8 years, and this is a quick comparison between acryl phakic and the Vision ICL phakic IOL. So the acryl phakic IOL actually, the difference is in the material. So it's made of hydrophilic acrylic, whereas the star ICL is made of porcine polymer. So because of the hydrophilic material, it's a bit more firm, and the leading hole is on the left side in the acryl, whereas it's on the right side in the star lens. The injection system is comparatively easy. It's just like loading a hydrophilic lens in a butterfly cartridge, and it can go through a 2.8 millimeter incision easily, whereas for the star ICL it needs a slightly larger incision, and the optic is aspheric versus star ICL, which is non-aspheric. So coming to specifications, it has a water content of 26%. The optic diameter, when I say the word optic diameter, it essentially means the clear optic. So the clear optic varies from 4.65 to 5.50 millimeters in the biotech lenses, and the overall length, it varies from 12 mm to up to 13.5 mm. This is basically to show that how much of the pupil is effectively covered by these lenses. So for a clear optic zone of 4.65, it covers up to 5.86 millimeters of pupil, and for a clear zone of 5.5, it covers up to 6.9, which is slightly smaller compared to the ICL. So for the torics, they have a nice customized models wherein you can just implant the lens at 0-180 degrees, and you can rotate them. They're already customized at 0, 30, 60 and 90 and 120 and 150. So if you have any axis which is matching with these axes, so you can just directly implant it horizontally. But if there's any axis which is between the two, then you can basically the maximum rotation required is just 15 degrees compared to star ICL, where it can be up to 22.5 degrees. So just a surgical video of showing the loading and implantation of the lens. So loading is very easy. So those surgeons who want to start with phakic IOL practice, I think these are the easiest lenses to start with, and it's just like loading a intraocular lens. So this is just about the surgery. So I've just made around 3 millimeters clear corneal wound, and I make a side port to stabilize the eye. And you must be careful to see the orientation of the lens. The leading hole must be on the left side. So this is a toric implant, and I'm using a Callisto system basically to orient the lens in its correct axis. And this is the ICL manipulator invented by also Dr. Sri Ganesh. The underside is sandblasted, so it helps in easy rotation and manipulation of the lens. So just briefly talking about this clinical study, which is already published in Journal of Refractive Surgery. This study was conducted in Netradhama Super Speciality Eye Hospital, and the aim was to compare the visual and refractive outcomes of ICL toric phakic IOL versus the star ICL over a period of 2 years. We had 50 eyes in both the groups. Minimum refractive astigmatism had to be 1 diopter or more, and of course, the usual inclusion and exclusion criteria were followed. The treatment planning was done based on the online calculators of the respective companies. Post-operative regimen was same. And this is the pre-op comparison of both the groups. Both groups were perfectly matched for age, sphere, cylinder, SE, keratometry, white to white, ACT, etc. Looking at the efficacy, both the groups had similar efficacy, almost, wherein 72% eyes achieved 20/20 or better vision in star ICL group versus 76% eyes, so almost similar. With regard to safety, again, there were no eyes that lost even 1 line of CDVA, so that it was excellent in both the groups. Spherical equivalent accuracy was also similar, with 80% eyes achieving SE between plus minus 0.5 in both the groups. And with regard to astigmatism correction, outcomes were slightly better in the ICL toric group, wherein 92% eyes were within plus minus 0.5 range versus 88% in the star ICL. Stability at the end of 2 years was also comparable. This is data at 24 months. Again, the mean values of sphere, cylinder, SE, UDV and CDVA were also comparable. The vault height and rotational stability was also studied, and the average vault reduced by 18 microns in the ICL group versus 13 micron in the toric phakic group. With regard to patient satisfaction, again, there were no significant differences. We asked them questions about spectacle independence, dysphotopsia symptoms, and overall satisfaction score. They were also comparable. Long-term complications, we did not have any significant complication in the ICL phakic toric group, whereas in the star ICL group, we did have 1 eye that required rerotation in the early post-op period, and 2 eyes of 1 patient that required exchange due to abnormally high vault. So to conclude, both toric phakic IOLs exhibited excellent safety, efficacy, stability, as well as rotational stability. In the long term, spectacle independence and patient satisfaction scores were comparable. So we can safely say that Indian manufactured biotech phakic lenses have fared at par with the foreign made lenses, and especially for those surgeons who want to start with their phakic IOL practice, I think these are the easiest lenses to adapt. Thank you so much for your attention.
Thank you very much, Dr. Brar. Our next speaker is Dr. Luthra. He will present his experience in biotech phakic IOLs.
Thanks, Boris and Sheetal. Very good afternoon to everyone. So I think we've actually gone through a very interesting session where a lot of the problems and complications with ICL were already covered. So I'll see if I come across those. I'll just skip those because there are quite a few that you can. So I was looking back and I found this video from 2006 when I started doing phakic lenses. And as you can see that then our understanding was not as great. So if you are trying to do wound-assisted injection, this is what you might end up with. So it's very important never to compromise on your incision size. And look at the kind of forceps I'm using. This was, I think, the first, third or fourth case that I was doing. And I'm trying to use a Hoskins to see whether I can either pull it out or push it back. So this is anathema. And that's why I put this video. No wound-assisted injections, adequate wound size, and handling the ICL not with any other forceps, but with the ICL holding forceps, as I will show you in the next video. With this patient, I actually got away by, kind of managing to pull it out. It took me almost 5-10 minutes, as I remember. But and the ICL didn't get damaged. But the correct way to handle it would probably be somewhat like this. Here I'm injecting, and I'm having a 2.8 incision, and still sometimes you will get a ICL which gets stuck like that, and when it happens all you have to do is gently nudge it out, and with the pull and push kind of a technique, then you can just pull it out using the ICL holding forceps itself.
and then you can go in and inject it. Usually works quite well. So don't get afraid if you have a situation where the ICL gets stuck in the wound. It can be managed quite easily. And going on, sometimes since we do make larger incisions than the cataract incisions for these ICLs, you will have a wound which may be leaky for some reason, and you're trying to hydrate it, and sometimes you'll still have a leaky wound. It happens very rarely, but it can happen in these funny corneas which may be a little friable or something. So what I did there was, I'm making a supraincisional pocket. I don't want to suture it because it's a toric ICL and I don't want any astigmatism induced. So I'm just making a small supraincisional pocket, and I will hydrate that pocket, and that makes sure that the wound gets nicely secure and then there's no leak. So that can be done instead of suturing the wound, especially if you're using a toric ICL. So you could have high vaults and low vaults. You can see here that one of my patients where I got almost a 1.39. So obviously this patient needed an exchange. But if you get high vaults, you can get angles which can be very narrow and occludable. You can get IOP spikes, pigment dispersion from the iris and into the angle. You can get pupillary block, even though it's very rare with these central holes. But with hyperopic ICLs, if you get a high vault where there is always a chance that you will, which doesn't have a centroflow, you can still get a pupillary block. And you can also get optic captures, as I'll show you in one more of my videos after this. And you can get a very low vault or a flat vault, almost no vault here, as you can see. And this can give rise to cataracts, even though again because of the centroflow we don't get cataracts as often as we used to get 20 years back. But you can also have ICL rotation, especially if you're using a toric ICL, because the ICL is basically undersized. And also sometimes you may have a subluxated lens in the periphery or zonular weakness when you will get these flat vaults. And even if you use a vault which is much a bigger size ICL, you will still not be able to get a good vault. So you have to be careful to look for any possibility of some kind of zonular weakness in the periphery. And then these vaults can be managed. So at the lowest vault that I would leave behind is maybe 150 to 200 microns. Anything less than 100, I would be watching out for any changes and then maybe go for an exchange if I have that. But the tolerance is good now. So you will also, if you have an undersized ICL, you will sometimes get these, lenses which are kind of sinking down, and a sunset syndrome kind of a thing, and you can see that the knuckle of the ICL is right there in the pupil. So these patients will not do well, especially if it's a toric ICL. Now in this patient you can see on one eye we got a good sized vault, and in the second eye we got a very low vault, even though the size was the same, but this patient had same white to white in both eyes, but one eye was anisometropic with very high myopia compared to the other. So obviously you will not leave it behind. So this was the OCT. One eye was good, 600 vault, and this was just about less than 100. And here we went with an ICL exchange. I think several people have shown techniques for ICL exchange, so I will not go into depths of surgery of how to exchange an ICL. Going on, you can, these are again the non-centroflow ICLs which we were doing 15, 16 years back. So you would occasionally get a cataract with low vaults. And if you got a cataract, you have to plan a surgery. The biometry remains just the same as what you would do for a routine patient. The ICL does not do anything to your biometry. And the surgical technique would be very similar as explanting an ICL and then going with a standard cataract surgery. So again, not much here that I should show you a full video. But going on to more important useful things, very rarely you will get an ICL which is upside down. So this patient was referred to me, was not referred, but patient came to me with having had ICL done somewhere with both eyes. And in one eye, both eyes looked good, but one eye had poor vision, was about 618. And that ICL looked a little funny to me with the iris kind of, being pushed forward in the periphery. And when we did the OCT, we found that one eye was having an upside down ICL, which the surgeon did not realize. So there's a value of the OCT, which is very, very important. This is the other eye which is looking good, and we eventually had to get this ICL out. It had caused a break in the anterior capsule as well by the time we decided to operate the patient. And these surgeries can be very challenging. These lenses are very friable, and you can see that big ring-like break which has happened. Once we removed the ICL, we saw this fibrotic ring. Patient was trying to decide whether to get the ICL out or not. Wasted almost 15-20 days, and by that time the lens had totally gone like this. So we eventually managed, and got the surgery through. Everything went off well. This patient a couple of months later went on to develop a detachment. So these eyes will not do well, and inverted ICL should be picked up and done on the table or next day itself. It should not be left there because it will never stay in the eye and have a good outcome. Now, sometimes you're injecting an ICL or an IPCL, as in this case, and you realize that it's opening in a funny way. You can still get away by twisting the injector. You'll see me twist the injector, and as I'm seeing that the ICL was not opening up correctly, this is an IPCL, and I'm just rotating my nozzle and getting the orientation right. So you have to watch out the haptics orientation, and if you notice that they are not good, you can rotate and get it in position without having to abort the injection or having an upside down ICL inside the eye. So this tweaking can be done and should be attempted, and even if then you don't get this right, you can of course just remove the ICL and then put it back again, which is not difficult at all. So going ahead, I wanted to share this one patient whom we had done some time back, very high myope with very high astigmatism and adequate AC depth but a suspect cornea. And you can see here that the Ks are touching almost 50 in one eye and the Kmax is 53 and 50. But she was about 38 and she had stable refraction for almost 10 years. She had been coming to me. AC depth internal was 3 millimeters and 2.92. And this was the cornea. We went ahead with deciding the ICL. Now the problem was that the white to white was between 11.6, which was done with the caliper, and 11.8 on the pentacam. And it's, for those of you who do the star ICL, you'll realize that this is where the ICL size changes. If you have a 11.6, you'll have to go with a 12.6 lens, and if you have an 11.8, you'll go with a 13.2 lens. So it was a dilemma, and as with keratoconic eyes, you have artificially increased AC depth. So we decided to go with the 12.6 lens instead of the 13.2, which the pentacam white to white was suggesting. And as we went ahead with the surgery, it was a straightforward. And once the lens was put into place, we were checking the vault with the AIOCT. And we realized that you can see on the right side, and I'll pause this for you, that there's almost no vault. This is the ICL and that's the crystalline lens, and the gap between them is not even 50 microns. So seeing that, we were very lucky because we had not returned the 13.2 lens that was still ordered and lying with us. So on table, we decided to exchange the ICL. So the intraoperative OCT can be a great tool in these rare patients, and we were lucky that we had both sizes available in the OT, the 12.6 and the 13.2. So we went ahead and explanted this ICL and replaced it with a 13.2 on table. And here we are getting the ICL out. Yeah, finish? Okay, the last one. Thank you. So with this, I was able to manage this patient. Thank you so much.
Thank you very much, Gaurav. And we have a last speaker who is Dr. Supriya. Yeah, she is already here. So
good afternoon, everyone. Yeah. Thank you. I'm presenting this talk on behalf of Dr. Sri Ganesh, who couldn't be here due to health reasons, and I'll keep it very short. This was supposed to be a very basic talk about the design and experience of our design, our experience in the design of the STAR ICL. So as you all know, the ICL is made up of a collamer material, collagen and copolymer, and this is bonded with UV absorbing chromophore, and it's a biocompatible material that's quiet in the eye. So these are the powers that it comes in, minus 0.5 to minus 14 diopters, and it corrects the astigmatism of up to 6 diopters of cylinder. The EVO Plus design of the ICL has an expanded optical zone, so it provides a better optical zone in patients with large pupils, and especially in cases such as night driving, they have better results and reduced risk of halos and glare. This is the lens design in the Vision ICL hyperopic model. So in the hyperopic model, the optical zone is much smaller. It's 5.8 standard optical zone. It does not have a center flow hole. It has 2 perioptic full thickness holes, and a preoperative PI is required with this model. This is again the hyperopic design. So these are some of the advantages of phakic IOLs over LASIK or refractive lensectomy. I'm going to skip over this slide because we know that there's minimal higher order aberrations, better quality of vision. It's a reversible procedure, and it preserves accommodation. So we did a clinical study in our center, 25 eyes of 14 patients with myopic astigmatism, and the STAR toric ICL was used. And these were the results. This is the design of the STAR toric ICL. The inclusion and exclusion criteria were pretty standard. Patients aged 18 to 40, the refraction stable for 1 year, optically clear cornea, ACD 2.8, clear lens, normal optical disc and retinal exam, and no other ocular diseases, pregnancy, etc. The treatment planning was done with an online calculator provided by STAR itself. So for this, mainly the white to white and antechamber depth is required, apart from the other biometric calculations. I'm just going to play a short video of the implantation of the toric lens. This is done with a 2.8 to 3 mm clear corneal incision. We use the Callisto I for the toric marking. It's a markerless system which has an overlay for toric ICL, so this can be used. And this is a standard 2.8 keratome. It's extended slightly beyond 2.8 up to 3 millimeters. Sodium hyaluronate 2% is used for all procedures. You can see this instrument has been designed by Dr. Ganesh. It is a Ganesh toric manipulator. It is a cannula which has a sandblasted undersurface so that the manipulation of the ICL can be done at the same time as injecting viscoelastic into the eye, and only a single incision is made. So side ports don't actually need to be made with this particular instrument. You can see that the roughened undersurface helps tuck the haptics under the iris, and it helps maintain the AC by injecting viscoelastic at the same time as doing all of the maneuvers, and only a single incision is required. I'm just going to skip ahead. This was the publication of this study. Post-operatively, these are the results. You can see that it has a very good efficacy index. 92% of eyes were 20/25 or better. No eyes lost any lines of vision. 48% of eyes showed no change in best corrected vision. 36% of eyes gained 1 line of vision, and 16% of eyes gained 2 or more lines of vision. Now you can see that this attempted versus achieved graph is quite tight. There was 2 patients that showed slight undercorrection, but no cases of overcorrection. And this is the refractive astigmatism, pre and post-op. You can see that it was within plus or minus 0.25 diopters. This is the stability over 6 months. The graph is fairly good. And these are the post-op outcomes. I'll just focus on one point here, that the pre-op best corrected vision minus 0.24 improved to minus 0.08 on post-op day 15 and remained the same at the 24-month post-op visit. So to conclude, ICLs exhibited excellent safety, efficacy, stability in the long term, and rotational stability as well. And surgically, it was very easy to adapt for anterior-segment or cataract surgeons who are beginners in phakic IOLs. Thank you very much for your kind attention.
Thank you very much, and I think we should conclude the session, and the new one will start now. We apologize for a little delay, and I hand over to the next speakers. Thank you.